Um, okay, so I'll start. Thanks so much for having me. I was asked by Srinivas to present what are the 10 commandments of CHIP, and the challenge with commandments is it sounds like it's a religious thing from above, and it's certainly not that. But just some ideas that I've had over the years of working through these cases and talking to these patients. So with that, I'll go ahead and get started here. Disclosure conflicts. So I'll start one by one and go through some data and examples. And I would start by covering areas of imaging, covering areas of physiology, hemodynamic support, just how you should think about these cases as a whole. And hopefully through this talk, you'll get some learning in that regard. So first, I'll start off by saying I do think physiology is really important to understand and to use when deciding to revascularize or not. Some people think that there's no role for physiology in CHIP cases, and I would strongly argue against that. The reason is that we know that our eyes can sometimes deceive us. And this is just an example of a slide shared by Martin Thomas, where these lines look curved, but in reality, because of the dots and the colors, they actually are straight. And so the same principle can happen when we think a lesion needs to be treated, but yet maybe it's not hemodynamically significant, and physiology can be the arbiter between those two things. So this is just an example of a patient that I treated, and I remember calling for the rotablator when I saw this initial angiogram. And then I remembered that the reason the patient was there was because they had normal stress testing and abnormal CT showing calcium, and was very, very concerned. And that's why we were doing the diagnostic catheterization. So rather than just treat it in an asymptomatic patient, I actually did FFR way down in the PDA, and it was normal. And it turns out that this patient actually ended up 2 weeks later having a retinal bleed. And had I stented this, probably would have lost sight and vision in that eye. So this is just a remarkable case in my mind that sears into my memory that we need to treat things for the right reason. And the physiology can help us determine or help arbitrate that. So generally speaking, when we take stable patients, not acute coronary syndrome patients, which is a different bag, what we're trying to optimize is taking the clinical scenario with the non-invasive testing, such as stress testing or CTA, and then correlate those two. And the angiogram further allows us to correlate to make a decision whether to treat. And all these three things go together. So symptoms, stress testing or CTA, and then the coronary angiography. Now, if those things all agree, you don't have to do physiology. If the patient has symptoms and a severe lesion and a positive stress test, go ahead and treat it. The reason to do physiology is when the data is either missing, so you don't have a non-invasive test, or you have a very, very fuzzy history, or there's discordance between the two. For instance, somebody without a lot of symptoms, but a severe lesion like the one I showed you. And then the physiology can help determine what to do. So you don't have to do it in every case, but you can be selective when you do it based upon these probabilities. I think it's also really important to remember that it's not a specific number that gets you to treat. Just because the FFR is 0.81 doesn't mean you for sure should leave it alone, or the IFR is 0.90. You have to think about this as a continuous marker of risk. And the lower the number is, the higher the risk is. So for a patient, if they have diffuse disease and they don't have a lot of symptoms and your IFR is 0.87, that's a lot different than that same patient with an IFR of 0.6, in whom the risk is going to be a lot higher for leaving it alone. So I think that's an important thing. And for our trainees, it's hard to get people out of the mindset of just not treating the number, but to think about it as a continuum. And the other thing to remember is that sometimes physiology will show you that it's not just you're leaving things alone. They'll show you that there's disease that angiographically perhaps doesn't look severe, but yet physiology can be severe, particularly in the LED distribution. So it really can help to make things more objective when you come to the cath lab. In addition to that, you can use it to plan your PCI approach. And this is just an example of a case that we did live for TCT, a lot of diffuse disease. There's disease in the second marginal, the first marginal, the bifurcation, and then the left main. And what we ended up doing in this particular case by doing a pullback is determining that we did not have to use 2 stents at this bifurcation. In fact, we didn't even have to stent the bifurcation because there was only a pressure loss of 0.03 across that. Most of the loss was in this area, in the left main itself, and obviously down here, which was not the pullback here. So we treated this, we treated this, we treated the left main, and we were able to avoid having to stent over that bifurcation. So it can be helpful. Now, what about other strategic approaches? And this is where we'll move to imaging. And there are going to be many uses of imaging in chip cases. We feel that it's kind of mandatory to do some sort of imaging in chip cases. And so for left main bifurcations, it can be really useful in terms of planning the strategy. And we just saw an example of that in the live case before. One reason for this is the left main is notoriously deceptive from an angiographic standpoint. And what one can appreciate from this slide is there are cases where the left main looks severe, there's no plaque. There are other cases where the left main doesn't look bad at all, and there is severe plaque. And so this imaging can help determine if this prognostically important lesion, the left main, ought to be treated or not. But beyond that, it can also look at the distribution of plaque and can help you determine what strategy to use. We often find that when we think the disease is only at the ostium of the LAD, it frequently extends back into the left main. And the circumflex, if you image it and there's not a lot of plaque there, you'll favor a one stent strategy over a two stent strategy, which reduces the risk of restenosis, certainly reduces the time of the procedure, and if the patient does come back, gives you further options. After you've treated the left main, you have to go back and image to optimize, because this is a lesion subset that typically should be favored by surgery. But if we're going to do PCI, we need to do it well. And so we need to expand our stents. And then we talked about this during the live case, that there can be acute stent deformation seen on IVUS. This was in the Excel trial. 7% of patients had this stent deformation that was associated with an increased incidence of adverse outcomes over the follow-up period. Now, beyond left main and bifurcations, what about calcium? Well, we can use imaging to determine how to treat the calcium. Should we use a balloon? Should we use atherectomy? What should we do? And the increasing awareness that what you're trying to look for and get is a fracture, which then allows the balloon and the stent to expand, is the way to getting the best outcomes. And we've actually developed an OCT-based scoring system that was published that looks at the thickness of calcium, the arc of calcium, and the length of calcium. And if all those things are bad, unfavorable, more thick, more angle, more length, then that would favor an atherectomy-based approach. IVL may be able to modify this to some extent as well, but that still remains to be determined. Now, beyond that, we talked in the last case about stent failure, and we want to image to determine why the stents failed. The reason for that is that it's common to have neointimal hyperplasia, like the case we saw before, but it's also extremely common nowadays, especially, to see underexpansion. And you're going to treat either of those things differently. You're not going to treat underexpansion with a drug-eluting balloon only. You have to expand the stent first. And similarly, if it's just neointimal hyperplasia, then maybe you need more effective therapy and you don't have to further expand the stent or overstretch the stent. So the reason to image for stent failures is I think it's also an empiric thing. It's the current stents in PCI are safer than ever. So if PCI fails, we got to figure out why it failed. Not only for our own sake and knowledge, like in the patient before, why did this happen? We needed to kind of know for our patient's sake. And then once we see what we find, we will treat differently based upon the mechanism of the stent failure. Finally, after we do our work, we really need to optimize our results because, as I said, these patients can come back frequently, and we want to make sure that the likelihood of that is as low as possible. Beyond stent failure, I would say that for stent optimization in complex disease, we want to use imaging because this is where the data supports the use of imaging. If you have a type A lesion in a 4.0 RCA, it's going to be very hard to demonstrate that you're going to get a better result if you image versus not imaging. But when the disease is more complicated, more diffuse, smaller vessels, calcium, bifurcations, that's where we may be able to see a difference. And that's exactly what's been shown by the data. This is data from the ultimate trial. This is the primary endpoint, but certainly the events have stayed separated with later term follow-up, demonstrating that IVUS-guided PCI was superior to angiography-guided PCI. As you know, the Illuminate 4 trial has just completed enrollment, and so this is more data that we're eager to get the answer to. Now, how do we do it? I told you before about how to do it with OCT. It's much easier. You measure EEL to EEL. You can then determine your stent size accordingly. With IVUS, people don't always know how to do it. And so the way we do it, just to show you, this is sort of the vessel size, which is outlined in the dotted line. That's the lumen size. You don't want to size according to the lumen if you can see the vessel. And basically what you do is you take media to media, and you can basically discount that by a half step down. So if this distance and this arrow here is 4, you'd probably use a 3.5 balloon and or stent for that type of case. And it's pretty straightforward. With OCT, you can be more accurate and you can go down to a 0.25 if you're looking at EEL to EEL. Now, this is a poll that I did a few years ago, and I think I've repeated it since then, but the principle remains the same. And that is, we asked if your father was having a PCI of the LAD, would you or would you not want him to undergo PCI with mandatory IVUS or OCT? And the majority of people responded, yes, we'd want him to do it. So if you would want it for your father, then why aren't you doing it for your patients? And that's a really, really, I think, fundamental point that, yes, there are cost constraints and we have to work through them. But if you feel that's the best for your parent, then that's something you want to bring to your patients. And that's why, personally, I think, especially for complex disease, imaging ought to be mandatory. The final part about imaging is that low contrast PCI with imaging, I do think is game changing. I don't use the word game changing a lot, but I will certainly say this allows you to do cases that you would otherwise not be able to do. I actually had a patient who had a contrast allergy in the middle of the case yesterday, despite being pre-medicated for it. And we did the rest of the entire case with just imaging only. And we were able to do the case rather than have to stop and take her off the table for another procedure, even though and we wouldn't really know what to do because she was already medicated for the contrast. So the important part about contrast is that despite the fact that in the NCDR, this is a large registry here in the United States, we see that contrast volume is clearly associated with the rate of acute kidney injury. Irrespective of the risk of the patient, interventionalists basically give the same amount of dye, which is remarkable. It basically means that I know how to do the case my way. I'm going to do the case my way, and it really doesn't matter what the patient risk is. That's crazy. We shouldn't be operating that way. We should lower the amount of dye we give if the risk of the patient goes up. And the way we track that is by the GFR. And so what we try to do is give less dye than the GFR for our patients undergoing PCI. And the way you can do this is you do a separate low contrast angiogram and you separate out the PCI. You interrogate lesions using physiology to determine what you need to treat. And then with imaging and wire guidance and actually matching this up to landmarks like the calcium and otherwise, you can place your stent successfully. And so this is just an example of that. And basically what we do is you put the stent in, you do it imaging guided, you expand the stent adequately. If you need to, you can check the post physiology, and you don't really need to give contrast. And this was published by Ziad Ali in European Heart Journal from our series at Columbia. Now, moving beyond imaging, let's talk about a few last things. One is hemodynamics and this issue of hemodynamic support. So when do you use hemodynamic support for chip cases? There's some people who say it's not a chip case unless I'm using hemodynamic support. That's not true. It's always going to be a complex or a patient who's higher risk for other reasons or something else type of case. You just have to think about the hemodynamics when you do it so the patient doesn't get sick. And so think about hemodynamic support when their hemodynamics are irreversibly bad. There's nothing you can do to fix them, or you're really expecting they're not going to tolerate what we're doing during the balloon inflations. And that last case was a perfect example of this, where because it's ISR, even though the disease looks bad, the patient's going to tolerate it pretty well for the most part, and the EF was normal, so you don't think you need hemodynamic support. I like showing this slide because it fixes the anatomy. What all three of these patients, each of these rows, each of these columns the patient have is a mid-LAD 90% and a prox RCA 80%. That's what they have. But look at the hemodynamic differences between this patient on the left with a normal blood pressure, normal filling pressures, and a normal cardiac index, and this one who has a marginal blood pressure, PA pressures are high, the wedge is 33, and the index is 1.4%. These patients with the exact same anatomy have completely different risks of decompensating during the PCI. So what I would do is the one on the left, I'd proceed, no problem. The one in the middle, I would proceed. And the one on the right, if you have to do it, put hemodynamic support in, but maybe just stop and take the patient off the table, diurese the patient, maybe give them some inotrope, tune them up, and then bring them back, and you might not need to use hemodynamic support. Now, if someone would say, well, why don't you want to use hemodynamic support? Well, the reason is because at present, It's another large bore access or a bigger access, and we'd like to do the case with the patient as safe as possible. So if there's no rush to doing it, there's no reason to jump into it at that time. So who do we consider support for? We basically consider it for patients with severe LV dysfunction or irreversible adverse hemodynamics who are undergoing multivessel PCI, and it's to support you during the stress of the ischemic burden during the PCI when we blow up balloons, and also contrast, because contrast does not contain hemoglobin and it makes people sicker. LV dysfunction with uncontrolled interruption of flow in a major branch, so difficult wiring, stent delivery, high risk of no reflow, or retrograde CTO through a major vessel. In other words, you're going to keep that patient ischemic for a longer period of time, and the patient's not going to tolerate that because the hemodynamics are bad. And if the EF is okay, we may do it in a patient with a last remaining vessel, but even that I put plus minus here. And as I said, the risk of hemodynamic support is real. There's bleeding complications associated with it. It's not something you would want to have done just gratuitously, and that's why it's important to think about when you're going to do it. This is for us, in our lab, when we tend to use it. I think oftentimes the cases with hemodynamic support get overrepresented on social media and other places because people are not going to talk about the type, A or B lesion they treated. They're only going to talk about their toughest cases. But that doesn't mean it's used in every case you do in the lab. And that's really important because the overall percentages here are quite low for overall use of hemodynamic support. And you modify what you're going to do based on pre-PCI hemodynamics. The bottom line is most of these scenarios involve low EF with some other threat of making the patient worse during the PCI, unless it's truly like a very, very high risk procedure based on the anatomy in a last remaining vessel. It's also important not just to show up in the cath lab and just do the case. Examine the patient first, look at the echo yourself, do the right heart cath, integrate all of these things together, look at the echo, make sure there's, for instance, no clot in the LV if you're going to use an percutaneous LVAD, and then manage the vascular risk as well to fully protect the patient from adverse outcomes. Volume and experience are critical, and these are the last two that I'll show you. Basically, if you look, for instance, at left main disease, if you're at the Fuwai Hospital in Beijing, which is the highest volume PCI center in the world, and you have your left main treated by a low volume operator versus a high volume operator, you have a higher mortality if you're treated with a low volume operator for basically the same low lesion subset. Now, of course, these things need to be adjusted, et cetera, but it's still an important point that in complex disease, experience matters. The same thing, by the way, is shown with CTOs and otherwise. And this is really important here in the United States, and India is not that dissimilar in this regard, where you have a lot of operators who don't perform a lot of cases. These cases should be performed by people who are very comfortable doing them. And if you don't have somebody comfortable doing the case, then you should work with somebody who is together so that you can figure out the best way to take care of the patient and do it safely. The reason I say that is because if you look in the United States at left main PCI, this was a report that came out 2 years ago in JAMA Cardiology, only 17% of operators and just over half of facilities did more than one left main PCI a year. That is remarkable. It shows you how little experience there is doing it. And you need to do it well if you're going to do it. And so use imaging. In this case, imaging was used in the minority of cases. You had support using in a large proportion of cases, which may be because of the unfamiliarity of how to do these cases. And it's just not a good way to do it. So you need to have high volume operators. And the same thing is true with CTOs. This is data from the New York State Registry showing that CTO operator experience was associated with outcomes in CTO PCI. The following thing I'll say is you want to be a physician, not a technician. And that's really, really critical when you're talking about how to do these types of cases, because sometimes you need to not do the case. This is an example of an 88-year-old woman had a non-STEMI with a pneumonia episode 3.5 months ago. She was at home. She was doing fine. She came in for referred PCI. The disease is horrible, as you can see. And when I spoke to the patient and her daughter, she said that she was fine and she was satisfied with her current quality of life, limited by her needs, and knew that she was going to have a high-risk intervention and preferred to avoid it. So we left it alone. In addition, this is a case that was referred to us for two-vessel CTO PCI, the LAD and the right coronary in a young individual. The circumflex is open. The collaterals are quite challenging if you can appreciate them. And here you see there's this conus collateral to the LAD, and the patient was referred for PCI but had symptoms and was otherwise a reasonable candidate. So the first question I asked is, why was the patient turned down for surgery? And the reason the patient was turned down for surgery is they felt that the lima there was no adequate LAD target. That to me seemed a little strange. And so what we did is we did a CTA showing there's an LAD there that's a reasonable target, and the patient went for bypass surgery. We could have done PCI and done 2 procedures, CTOs that are higher risk and more complicated. But for a long-term durable option for this patient, lima rima, surgery is going to be a good option. And so that's important to do. That doesn't mean we only do surgery and we only do medical therapy. We need to use our skills as needed in the appropriate way. And so this is a patient who presented initially with aortic stenosis that was moderate to severe, an EF that was down, non-STEMI, and a tight left main and an occluded right coronary artery. The patient was actually transferred to our institution for surgery, but while on the floor, went into VF. Now, interestingly, the patient was on the surgical floor, and so the surgeons immediately cannulated the patient and called us to the cath lab because they could not defibrillate the patient because the left main was down and the right was occluded. But the patient was actually moving to pain because they were fully on support on ECMO, despite the fact that the patient was fibrillating. It's kind of a crazy situation. So we actually brought the patient to the cath lab, despite not really wanting to do it, but the patient was moving. We thought that we could potentially save the patient's life. So the nurses and everybody in the lab kept saying, we should defibrillate, but you're not going to be able to defibrillate if the patient has no flow. And so what we did while the heart was fibrillating on ECMO is we wire the circ, we wire the LAD, and then we ballooned to restore flow. We then defibrillated and the patient came back. We then basically completed culotte stenting of the left main. Here's what the final angiography looks like after kissing balloon inflation, where we restored all flow and circulation to the left system. We actually put in an impella to unload the LV because the heart was clearly going to be stunned. And the patient actually survived and was discharged with a full neurologic recovery. However, the patient had a vascular complication and had an amputation of the leg at the site of hemodynamic support. So this was a challenge that we had to deal with, but we did save the patient's life in the end. So just to conclude, I would just say the fundamentals of the CHIP mindset are that the indications for the case, the clinical indications, don't change just because a lesion is harder to treat. We need to train ourselves to learn how to take care of these patients, but we also need to know how to do it and when not to do it as well. And I tried to convey that in a piece I wrote as a response to a CHIP training document by Robert Riley and Jack in 2020. And I'll just read you what I wrote at this end. I said, despite its reputation as a technical subspecialty, interventional cardiology has always been about more than just the wires, catheters, balloons, stents, and adjunctive devices. It's the cognitive aspects of the field that are in many ways the most enticing. Knowing why, when, and when not to do something, and additionally, how and when to stop, are in many ways far more important than the actual technical aspects of the procedure itself. So with that, I'll conclude. Thanks so much for asking me to speak, and I'm happy to take any questions at this time. Thanks.
Thank you, Ajay. Great talk. Thanks for stressing the fact that interventional cardiologists should not work like technicians and see more like be responsible for patient, evaluate patient clinically, do echo yourself. And sometimes when you're planning these CHIP procedures, it's very important point what you mentioned is a pre-treatment and probably diuresing them well and appropriately preparing them for elective cases at least is very required. And that's where I think our clinical skills also matter. And you've shown a tremendous case where we could also save. Sometimes I feel God is great. Some patients who are, in spite of all their sickness and arrest, they'll become all right. Some of them come walking and land in trouble. That's how these cases make us humble. And thanks for your excellent message for youngsters. And many of appreciations are coming in chat. Ajay, great message, and many of them are congratulating. The congratulations are fine, but any other questions or comments which anybody has had to ask Ajay, please feel free. Damodar, you deal with a lot of CHIP cases there. Want to ask anything to Ajay?
It's a great message, and the one sentence I really like from Dr. Ajay's message is the last line, that be a physician, not a technician. That is what we need to. And as far as the CHIP cases, as he nicely pointed out, that we have to think beyond the complexity of the lesion. We always look at the complexity, anatomical. Whenever we deal with PCI, we will talk only about the anatomical complexity. he nicely pointed out the filling pressure, LV function. But one question I want to ask from Ajay is that some of the patients, which sort of CHIP patients do you really put a prophylactic ECMO, anticipating this patient may, arrest on the table, and our Impella may not give that much support in a no rhythm patient, in a very adverse hemodynamic patient, or will you go with only Impella in such patients? Can you please enlighten on this?
Yeah, I mean, for elective PCI, I can't think of a patient where we needed to use the level of support that ECMO provided over the Impella CP for elective case. There are cases. There's one case I had not too long ago where the patient was really, really big, and we had to do a very complex PCI of the left main with atherectomy, and so that patient we put in an Impella 5.5 because of his size. But I'll tell you, for high risk PCI, you don't need that same degree of support that you do for shock. And Sushil remembers, because he enrolled a lot of patients in the initial Protect 2 trial, and that was with the 2.5 device. And he has an amazing case that he was involved in where he dissected the left main, shut the circ down, and the 2.5 provided plenty of support in that case. So my feeling is that if you're going to use support, and as I emphasize, it's still the vast minority of cases. It's not a lot of cases, but if you're going to use support for elective PCI, typically that will be enough.
At least in cases who got a history of cardiac arrest in the recent past, would you consider higher support more than either a 5 Impella 5 or something like that in a case with a recurrent arrest with a history of recent VF or VT?
Yeah, I mean, if the patient is arresting, or actively arresting, that may be a patient where you just do it on ECMO, period, and then you can save money by just doing it on ECMO. But the shock scenario is different than the elective high-risk PCI scenario. Sushil, you were saying something.
Thank you.
No, I guess I was more asking a question for in India, the cost and availability of Impella versus ECMO. How is that factor into some of the decision making? And if you're going on ECMO, I mean, the importance of vascular complications, as Ajay noted in this one case, is an important consideration. And what level of support do you do on ECMO, and how do you manage the cost and availability factors?
In India, ECMO is available freely because the company also moves out on consoles, and our CT surgeons are quite comfortable, if not the cardiologists. In our place, we also put these devices. Especially in the COVID times, also a few cases were done, and the companies were supporting in various other hospitals. Whereas Impella is not given free. Actually, it's not given for shock situations in all the labs, all the hospitals. It is given only for some selected hospitals, but they are encouraging more for protected PCI type of indications rather than shock now. So that's a problem with Impella availability in various centers in India.
Yeah, I would also have to say that, if you have AMI shock, which can recover, the CP device may provide enough support for that. But if you have truly, really deep shock and recurrent arrest and that sort of thing, we often end up having to escalate those patients to Impella plus ECMO, or the 5.5 or something more than what the CP will provide. So I actually think that that's pretty appropriate, because my sense is, especially if you have ECMO available, if the patient's in deep shock, you're going to find that the CP was not enough to take care of those patients.